Good morning, dear BCMCH family. Welcome to one more edition of Quest, wherein we have a quest to bring all our faculty and students together in one platform once a week to listen to our erudite faculty, our own stalwarts, and also faculty from outside. So a warm welcome to each one of you. And before we start our proceedings, may I request our chaplain Achin, Reverend Father Thomas Verghese Achin, to start with a word of prayer.
Shall we all stand for the prayer, please? പിതാവിനും പുത്രനും പരിശുദ്ധ റൂഹായ്ക്കും സ്തുതി ആദ്യം തന്നെ ആമേൻ. ഞങ്ങളെ അതിവാത്സല്യമായി സ്നേഹിക്കുന്ന ഞങ്ങളുടെ സ്വർഗസ്ഥ പിതാവാം ദൈവമേ, ആരും കാണാത്ത ഒരു നവംബർ 2 ഞങ്ങളിതാ കാണുന്നു. പുതിയ കാര്യങ്ങൾ കേൾക്കുവാൻ പോകുന്നു. പ്രത്യേകിച്ച് അതിന് ഞങ്ങളെ കേൾപ്പിക്കുവാൻ പോകുന്ന ഡോക്ടർ ആഷു മത്തായിക്ക് വേണ്ടി പ്രാർത്ഥിക്കുന്നു. ഇതുപോലെ ഈ ആദ്യത്തെ വ്യാഴാഴ്ചയും അവിടുത്തെ നാമത്തിൽ കൂടുവാനും പുതിയ കാര്യങ്ങൾ കേൾക്കുവാനും ഗ്രഹിപ്പാനും അത് മറ്റുള്ള ജീവിതത്തിലേക്ക് പകർത്തുവാനും ഞങ്ങൾക്ക് ലഭിച്ച വിലയേറിയ സമയത്തിനായി നന്ദി. ഒരുമിച്ച് ഞങ്ങളെ അനുഗ്രഹിച്ചാട്ടെ. പ്രാർത്ഥന കേട്ടതിനായി സ്തോത്രം. യേശു ക്രിസ്തുവിൻ്റെ വിലയേറിയ നാമത്തിൽ തന്നെ ആമേൻ. പ്ലീസ് ബി സീറ്റഡ്.
The topic for the day is Perioperative Medicine, Building Models of Care. And we have our dynamic and charismatic leader, the Professor and Head of Anaesthesiology, Professor Dr. Ashu Sara Mathai, ma'am, taking the session. Let's put our hand together and welcome her for the session.
Thank you, Dr. Jacob, and thank you all of you for coming here this morning. As Dr. Jacob asked me to take a session for the Quest in BCMCH, I was wondering what would be a topic that would be equally interesting and useful and applicable across the specialties. And since perioperative medicine is an emerging field, is a field that's developing pretty vastly over the past couple of years. And this is something that integrates a lot of specialities across the hospital. I thought this would be a matter of interest to some of us at least, especially my surgery friends, my surgeons. This is something we could possibly look at implementing in the future, though many of us in many ways are doing several of these steps already. But this is bringing those steps together to develop models of care for our patients. This is a subject very close to our hearts as a department, and we would definitely love to explore how we can move ahead with you on this journey. So what is perioperative medicine or perioperative care? This is the practice of patient-centered, multidisciplinary, and integrated medical care of patients from the time you contemplate surgery, from the very early stages of contemplation of surgery until full recovery. So it covers the entire spectrum, the entire gamut of preoperative, intraoperative, postoperative, right till the time the patient goes home. And who does this benefit? As we know, as we realize, that this benefits that small high-risk cohort of patients who actually represent a minority of our surgical population, but who comprise a majority of the perioperative mortality or the perioperative complications. And so this is an individualized, a patient-specific, and a procedure-specific model. And we look at whether this is applicable to us in our institutions right where we practice. So as I said, it is a multidisciplinary initiative. It effectively identifies and meets the complex medical needs of patients who are at risk. So we are narrowing this down to the patients at risk and who are likely to have some of those adverse effects of the surgical treatment. This pathway or this model prescribes interventions before, during, and or after surgery and may extend beyond that index admission for surgery. It is driven by the increasingly complex surgical procedures that we are doing now and we are going to do in the near future, and the advanced anesthetic and surgical techniques, and also the kind of population that we are seeing now. It involves a lot of shared decision making, both patient, doctor, and interdepartmental between physicians and nurses, between all the caregivers. And as a model, it offers some unique teachable moments for the patients to adopt lifestyle modifications. So this is a re-engineered pathway. We know that the standard pathway, I'm sorry, the size of that font is small. Let me just read through that. So we have a patient coming to the hospital who undergoes diagnostic tests and imaging, and you think of surgery for this patient. We may or may not have some multidisciplinary meetings. He comes to the surgical clinic and then comes for the pre-anesthetic assessment, where they are classified as low, moderate, or high risk. The high-risk patient perhaps is delayed a bit, undergoes further investigations, optimizations, there is further decision-making, and then they all go in for surgery with or without post-operative critical care. What is this re-engineered pathway? So right at the time that surgery is contemplated, in those very early stages, when you're working up the patient for diagnostic tests and tumor staging, we begin risk assessment for these patients. So simple online or risk stratification assessments are made, including patient-reported functional capacity assessments or specified cardiopulmonary exercise testing. And they're classified as low, medium, or high risk. And then they move on to a high-risk clinic where you have collaborative decision-making with multidisciplinary team, and they're put through a series of tailored medical interventions. Now, what does this include? Now, abroad, they have this concepts of surgical school, where these patients are educated. They undergo lifestyle interventions like cessation of smoking, cessation of alcohol, management of nutrition. So obese patients are put through a regimen which will help them achieve a greater level of fitness before surgery. They are put through some exercise interventions. Some of the comorbidity management includes management of anemia, comprehensive geriatric assessment, optimization of their renal, cardiac, respiratory functions. And after all of that, and while that is being done simultaneously, while that plan for surgery and the workup for surgery is happening, and then he comes to the pre-anesthetic assessment, where he's then taken through a specific stratified perioperative package. And then the care continues into the intraoperative and to the postoperative period. Here I've mentioned only the preoperative pathway. So this is an individualized care plan and involves even surgical schools. So as you can see, this is highly patient-centered, the patient at the middle. It is very individualized, standardized, and specific, and involves a lot of people around the patient. Various fields, various specialties, all coming together when we identify a patient who can possibly go through this surgical pathway. And we have simultaneous collaborative decision-making, comorbidity management, and collaborative behavior change. So because we recognize that patients have certain fixed preoperative risks and certain modifiable preoperative risks. The modifiable ones include anemia, COPD, diabetes, optimization of some of that, along with lifestyle modifications. Now, does this really make a difference? What are we talking about? Are we talking in the air out there? Is this really important? Now, the global patient outcome after elective surgery was a study done over 7 days. So various hospitals across the world recruited who did surgeries, elective surgeries over that 7-day cohort period, studied the patients who came in for elective surgeries. And this was results published in 2016. They looked at 27 low, middle, and high-income countries. And they included 474 hospitals in 27 countries, close to 45,000 patients. And they had a median hospital stay of 4 days. Now, they found that 16.8% of patients developed one or more postoperative complication. Now, this is a very pragmatic, on-the-floor study kind of thing. So all the patients within that cohort period were included, coming in for elective surgeries. And they noted that while the overall mortality was 0.5%, those who developed complications had a higher risk of mortality, close to 3%. Now, unfortunately, there were no Indian hospitals included in the study because the minimum number of hospitals needed to be eligible to be included in the study were 10 hospitals. And at that time, I think they didn't have 10 Indian hospitals who recruited into the study. But the 4 hospitals that did recruit into the study published their data separately in another article. And they included 207 patients, and they said that 28% of those patients developed postoperative complications compared to the global average of 16.8. And while the overall mortality was 2.4%, those who had complications had a higher chance of mortality, close to 9%. And this is, the global average is 3%. So our Indian population patients are probably having a higher risk of complications and a higher risk of mortality, especially if they had complications. And if you looked across the specialities, the upper GI, lower GI, cardiac, thoracic, and vascular patients seem to have those higher risk of mortality. Now, age was a very significant factor. If you look at the patients who had complications, the average age of patients with complications was 61 years compared to 54 years in those without complications. I'm sorry. Yeah. And if you look at patients who died, the average age of patients who died was 69 years compared to 55 years in those who didn't die. This was the mean age. The same was seen with the median age average. The NAP7 data, that's National Audit Project data, which include data from UK, Australia, and New Zealand, said that the average age of patients over the last decade has increased by close to 2.3 years. So 1 decade ago, we were operating average patients of the age group of around 50 years, and now we've come to 52.8. I looked at the BCMCH data over the last 3 years. We are somewhat similar. So we have an average adult age of 52.8. The average BMI of patients had also increased by 2 points over the last decade. So we are dealing with slightly more overweight patients. And the proportion of patients who were low risk for complications had actually decreased by about 1/3. And none of us know the effect of the COVID pandemic on all of these numbers. So we still don't know, and we are yet to find out. So what is this high-risk group that we're talking about? They are the elderly, they are the frail, they are the ones with multiple comorbidities, they are the ones who have polypharmacy, and they are the ones who are undergoing major surgeries. So does putting them through a specific perioperative care pathway make a difference? The Center for Perioperative Care published their data in June 2020, and they looked at the impact of this perioperative care on healthcare resource use. And they looked at 152 systemic reviews and said that putting these high-risk patients through a specific care pathway reduced the length of stay of the hospital by about 2 days. It reduces the healthcare costs, the number of cancelled surgeries, the time spent in the theatre, and admissions to the ICU. It also improves their pain, fatigue, early recovery, overall satisfaction, and survival, and tended to better use evidence-based care when you put them through these pathways. Again, I looked at our data. Unfortunately, we don't have much data of the ICU shifts. It's not very ordered data. So I looked at the last 3 months of patients who were shifted to the ICU and who had undergone elective surgery. So adult patients who underwent elective major surgeries and were shifted to the ICU. We excluded patients who underwent surgeries under local or non-operating room procedures. So about 1/3 of our patients are elderly. This is adult elective major surgeries. About 1/3 are elderly, and about 10 to 12% of those tend to go to the ICU. So this is data over the last 3 months. The orange are the elderly patients, and the little gray are the patients who are going into the ICU post-operatively. We have some early data on the impact on the prevalence of frailty in our patients. This is part of the thesis of one of our students. And in elderly orthopedic patients undergoing surgeries, frailty is very common. So only 9 patients, that is 3% of patients above 65 years, are not frail. The rest are frail. In fact, 50% of our patients have moderate to severe frailty. And frailty is very closely associated with age. If we were to look at the severely frail patients, they are in the age group of 75 years. And the moderate frail group is around 72 years, while the mild frail group are about 69 years. So age, frailty are closely related. We also have some retrospective data published from our department on the impact of frailty and comorbidity index. And we found that moderate to severe frailty patients have higher mortality. And patients with a higher number of comorbidities had a greater length of ICU stay, and there was a greater dependence on their activities of daily living after their index surgeries. So this is something that clearly points to us thinking or contemplating of such pathways and thinking of how we can give better individualized care for that high-risk vulnerable group of patients. So what is perioperative medicine, or these standard pathways that we're talking about? It involves interventions in the preoperative period, like I said, risk assessment, optimization, care stratification, consent with shared decision making. Intraoperative is quality intraoperative care using evidence-based interventions, and post-operatively sending them to those appropriate wards where they will be closely monitored, making sure that their pain and fluid management is taken care of, taking care of their comorbidities, and putting them through some of those ERAS, or the enhanced recovery after surgery pathways. We'll come to each of this. So coming to the first, what is preoperative optimization? What are some of the things we can do in the preoperative period? Very importantly, risk assessment. We have a lot of risk stratification tools in the department, both cardiac, pulmonary, looking at outcomes, where they should be going. We have functional status assessments, both self-reported by the patients and objective functional status assessment tools like the cardiopulmonary exercise testing. Putting patients through a preoperative exercise regimen helps a lot. Now, the few patients whom we put through the ERAS pathway, our gastrosurgical patients, we found that there was a huge benefit to the patient in terms of their post-operative recovery. So, putting them through an exercise regimen aims to improve patient outcomes by enhancing their ability to withstand the surgical stress response. We also need to optimize their nutritional status. Many of our patients are either undernourished or overnourished or obese. And many report weight loss in the period immediately preceding surgery. So nutritional optimization, I'll come to that in more detail later. Psychological intervention, it helps the patient greatly to know what is coming to them. Many of them fear the whole surgical process because this is an unseen, unknown territory for many of them. And so talking them through the steps of surgery, what to expect, what is going to happen when you're in the OR, what is going to happen in the post-operative period. I'm going to be taking care of your pain, and this is how I'm going to be doing it. It allays their anxiety to a great deal. And these surgical schools, as they have abroad, actually takes them through those stages, familiarizes them with the OR environment. And it's said that allaying their anxiety has an impact on their pain and their recovery profile. Collaborative lifestyle modifications. Now, the perioperative period is a very teachable moment. The patient is most scared and most likely to listen to your advice in the perioperative period if you tell them that stopping cigarette smoking for even 2 weeks can have a significant impact on your intra and postoperative outcomes. Patients, if ever they will listen, that's probably the time they're going to listen to that lifestyle modification. Again, alcohol or recreational drug use, those are the teachable moments that you can have in the perioperative period. And like I said, surgical schools where patients learn about their surgical journey. So these are some of the exercise modifications. The patients we've referred to our PMR department have greatly benefited, though we've done that in a very small group of our ERAS patients. They prescribe aerobic exercises, resistance exercises, balance and flexibility exercises, of course, based on their age and their functional capacity. So these exercises are very specific and prescribed for the patients. And putting them through even a 2-week regimen has a great impact. They're also taught inspiratory muscle training, which greatly helps them to breathe well and cough in the postoperative period, reducing their risk of postoperative pulmonary complications. And patients are asked to maintain a record of their progress even after they go home. And they're taught some home-based exercises as well as some supervised exercises in the hospital. The role of prehabilitation has been studied, and it is found, so prehabilitation is beginning exercises before surgery, and rehab is after surgery. So patients who have both prehab and rehab fare the best. That's the blue line you see. Those who have no prehab and no rehab do the worst, that's the gray line. And the patients who have either one of those are the ones in between in terms of coming back to their preoperative functional level. What are some of the nutritional screening tools? We have a variety of tools that are being used, which combines anthropometric measurements, their weight loss, their history of weight loss, their protein intake, and so on and so forth. And the whole aim of nutritional screening tools is to give them what is called a preventive kind of help rather than a reactive boosting of their nutritional stores after surgery. So giving them a lot of protein after surgery doesn't work as well as giving that before surgery. And you're shifting them to an anabolic kind of diet. You're building up the muscle mass instead of to take care of the catabolic stress that's coming ahead. And this is to be started as early as possible in patients right when you're contemplating surgery. And it is important, the ASQPI initiative has really stressed on the importance of this preoperative screening of nutritional status and the key role of nutritional supplements, protein delivery rather than calorie delivery, and the early initiation of this post-op nutrition. So early feeding in the post-operative period. What are some of the comorbidity managements? Anemia has been studied in a lot of populations, and rather than put them through that risk of blood transfusions intraoperatively or postoperatively, build their hemoglobin. So the target recommended is 13 gram %, and assess if the patient has any deficiency, classify their anemia, and start treatment right when you're contemplating surgery. And there's so much of evidence which says that not correcting them tends to make the patients do poorly, and you end up risking giving blood transfusions. Other comorbidity management includes management of frailty. Now, this is a little bit of an unknown subject, assessment of frailty, but we increasingly recognize that frailty is closely interlinked with delirium, especially in the postoperative period. So the elderly patients who are frail have a much higher risk of postoperative delirium, which tends to end up with them being in the ICU, in the hospital much longer, on a lot of sedatives, and on a lot of polypharmacy. So assessment of frailty and the risk of delirium in the preoperative period itself. We have screening tools that are available, and putting them through the care pathways, even intraoperatively and postoperatively. So things like avoiding benzodiazepines, avoiding opiates, taking care of their pain, making sure their temperature is normal both in the intraoperative and the postoperative period. That goes a long way in the management of our elderly, high risk and vulnerable group of patients. And of course, managing other comorbidities like diabetes and hypertension, encouraging weight loss, diet modifications, etc. Some of the intraoperative things that we can do, and I'm happy to say that this is something that most of us are doing in the intraoperative period, specifically for major surgeries. Tailoring anesthesia to the requirement of the patient, maintaining normothermia, looking at opioid sparing or opioid-free kind of anesthetic techniques, and going for more regional blocks to take care of their pain. Guided fluid management. So we are going with more restrictive kind of fluid management with goal-directed fluid boluses rather than a liberal fluid administration in the intra and post-operative period. Minimizing hemodynamic fluctuations. So the vulnerable group tend to get in outlines early and tend to have vasoactive supports put in before they even start the surgery. Minimizing blood transfusions and putting them through standard pathways of care like the ERAS protocol. Postoperatively, what can we do? Again, individualized care plans, changing that paradigm shift in our thinking from the reactive model of care, of handling complications, to the more preemptive model of postoperative care. For example, patients who are at risk for delirium, you try and make sure that they're warm, you try and get their spectacles and their hearing aids back, rather than put them through a period of none of those and risking that delirium that is going to happen in the postoperative period. So some of those interventions. Early and appropriate referral to the critical care units, and development of post-anesthesia care units. So make those post-operative or post-anesthesia care units a much better unit, to be a bridge or a gap between the critical care and the ward care. Pain management planning. Now, this is something that should start even before the surgery. And this is something that we talk with the patient over as to how I'm going to manage your pain, so that you allow early patient engagement with pain. Education. Education goes a long way with the patient's actual sensation of pain and the reporting of pain. and appropriate postoperative planning. Again, opioid sparing, multimodal techniques, not just one drug or two drugs, but taking care of pain through different modalities. Actively screening for postoperative delirium or postoperative cognitive dysfunction, and dreaming for the patients. Dreaming is early eating, drinking, and mobilizing. So they say that if you do that within 24 hours of surgery, there is shorter hospital stay and reduced complications. What is our story so far? Now, like I said in the beginning, we have taken baby steps into some of these areas, many of these areas, but they are here and there. And what we ought to discuss going forward is how can we bring these together. We have begun frailty assessment and functional capacity assessment as a part of our routine preoperative assessment. We have begun screening for MINS in our high-risk group. MINS is myocardial injury in the non-cardiac surgery patients. So patients who have history of coronary artery disease or stroke or cardiovascular illnesses are at a higher risk for those events in the postoperative period. So we do their surveillance with TROP-I before and after surgery. Identification of those special care patients. Of course, this is few and far between, and we can definitely do a lot more here. But of course involving a lot more resources. Patient information in the form of multimedia, AV aids, we've begun that in baby steps. Modification of fasting times, we've actively looking at how we can reduce fasting times. Again, prolonged fasting has a negative impact on the patient's recovery, especially in the elderly, high-risk, vulnerable group. We have one trained faculty who's trained specifically in perioperative care medicine in Canada. Dr. Jinsey is trained in that. But we are also looking at training some of our preoperative and postoperative nurses. And I want to say Sister Ramya, who's in charge of the postoperative unit, has helped us greatly, and she's taken huge steps to train her nurses in some of these aspects. We have implemented the ERAS protocol. Over the last 2 years or so, the ERAS protocol is being done in many of our gastrosurgical patients. Postoperative pain services, this is something that we've started officially since 1 year, and then more actively since the last 1 month, where we are regularly doing postoperative rounds on day 2, day 3 of our major surgery patients. And we are offering blocks even in the day 1 and day 2 of the postoperative period, and looking at more opioid-free analgesia kind of pain relief. And addressing some of the common complaints like postoperative sore throat, pain, and doing patient satisfaction surveys. Some of you would have seen these kind of posters in our surgical wards. We're hoping to educate our nurses and distribute them in the wards. So these are simple visual reminders for our nurses and patients that you don't have to have those long fasting hours. 2 hours of fasting is enough if they can be encouraged to take clear fluids, water, milk-free liquids, non-pulpy liquids, even up to 2 hours before the surgery. So we are encouraging our surgical nurses to wake the patient up at 6 in the morning and give them water, black coffee, black tea, non-pulpy fruit juices like apple juice. And post-operative, we recognize by our satisfaction surveys, we've recognized that thirst pain are one of the few complications that are reported by most patients. And we've begun to screen patients for that actively and offer treatment. This is some of the pictures of the nursing education, some of the AV information that we have. If you come to our 4th floor preoperative area, we've begun, and we have a long way to go, but we are going to go there. And that's the patient sucking on an ice popsicle in the postoperative period. So this is something that we are actively looking for and ensuring that patients don't encounter dry throat or sore throat in the post-op period. Future directions, this is an evolving specialty, and in many ways it's a logical development of what we are already doing. And so this is something that we can take further, but of course we have a lot of uncertainties. We have boundaries issues. When we began our ERAS care pathway and when we began our MINS surveillance, we had a couple of issues with, are we crossing boundaries with other departments? And we did have to have multiple discussions with other teams to talk about some of our concerns. We have concerns with funding and time. We have concerns about changing these set patterns. This is the way we've always done things. This is the way we've been taught. And it is difficult to change set patterns. Of course, we have to acquire skills, knowledge. There's a lot of hard work into developing protocols specific for our population, for the Indian population, for the Kerala population, for the BCMCH group of patients. So we can't just blindly adopt protocols that are out there. We have to tailor them to our requirements. And we have to formulate those care pathways and build teams who will spend that extra effort into thinking and sorting out, looking at our data. We have to build our PSCU, and a lot of quality audit and research is required for the future. Thank you.
Thank you so much for that wonderful session, dear Ashu ma'am. I learned one new term, prehabilitation. It was really wonderful. Now we open the house for questions.
I would like to thank Dr. Ashu for this wonderful presentation. I think you've stressed on a lot of things we as a team in cardiac surgery practice, because we are a small team, close team, and we work together. And I think, as you said, collaboration, discussion, working together is very important, and trusting each other, and also understanding that we are all working towards the good of the patient. I think I hope we can develop better relationship between the post-op anesthesia team, post-operative team, and also the surgical team. And I'm sure a lot of things you discussed here will go a long way towards the early recovery and betterment of our patients. Thank you.
Thank you, sir.
Any questions?
That's a very nice talk, madam. Why don't we start ERAS and gynae patients?
Dr. Kurla, you'll have to tell me why, because we did have some sessions with the gynae department, and we did discuss how to take this in the gynae department. Maybe we'll have more discussions. But we'll have to have those patients, at least initially we'll have to have those 1 or 2 patients whom you identify, who are undergoing, whom you are planning those majors, those cancer patients with pelvic node dissections, those major surgeries. And we can start with those 1 or 2 and then take it forward. Dr. Rekha will know this.
Ma'am, I have a doubt, a question. Ma'am, you said polypharmacy will be greatly reduced with preoperative and perioperative.
Polypharmacy is a risk for some of the post-operative problems. So patients who have polypharmacy. So there are a lot of drug interactions which you're looking at. If the patients who are on multiple, more than 5 groups of medications coming into because a lot of our anesthetic drugs can have reactions. 2, there is a risk found with post-operative delirium in those with polypharmacy. And 3, it's supposed to increase our nursing times in the preoperative, post-operative care, to keeping a track on all the medications. So definitely somebody needs to be looking at tailoring these medications and giving them optimally.
Can be an interesting study too.
Yes, absolutely.
Regarding post-operative pain management, I just one point. There is increasing tendency among some surgeons to ask for fentanyl transdermal patches to manage post-op pain. I think that is not the ideal thing. You know better than me, because it is not suited for acute severe pain. Patches are not at all indicated for such cases, and also it doesn't have immediate onset of action. And once it starts releasing the medications, you don't have any control over it. So it should be discouraged. I think there should be a discussion among the surgeons.
Yes, so tailored to the patient's needs and optimally timed, of course, and multimodal. So we are not talking of just giving one drug. So give small doses of multiple ways of handling pain.
What have you done so far about the temperature regulation in the OT?
I think we can ask Mr. Ajit about this issue, sir.
Some days it is freezing, and that is the main cause of patient discomfort.
I agree.
And you blow the hot air onto the patient's body or throat, and that causes sore throat also. Invariably, that patients have sore throat. That's a major point.
Yeah,
that
it
should
is
be looked-
multifactorial, but I guess that
And
could
all the
also-
anesthetists are wearing gowns and all to stay warm a little. But the patient is shivering.
Yeah, as Dr. Ashu had told, pain and warmth are two things that have been totally undermined from the patient's view. But what Professor John said is important. But the problem is that to tell the people, the team, that such things are important to control temperature, surgeons should be the first ones who should take the lead. We are outnumbered by the number of surgeons. There are around 30 specialties, and you can multiply it with maybe 4. So I think that you people should not put the entire blame on us. We are struggling to somehow get these people to do these things. And you as a team should put pressure on very critical things like pain, like hypothermia, all those things. There is hardly any input except on all these forums. And she as a person will never be able to put pressure on somebody like Ajit, as we all know. So I think the surgery team should come together, you should put pressure, and you should get so many things. Hypothermia is just one thing. And get the nursing intact, get all the machines and things that are required in the OT. And we are far from near to what we should be.
Good morning, ma'am. Ma'am, it was said that in patients with elderly patients, frail patients, develop post-op delirium commonly. So, will keeping a companion with them perioperatively, will that reduce the
Yeah, so post-operatively, intraoperatively, of course, that's not possible. But post-operatively, yes, early moving them back to where their caregivers are or encouraging those visits more frequently, that does make an effect. So seeing familiar faces rather than strange faces, they lose their day-night variation, their sense of where they are on multiple medications, all of those factors contribute, cold, pain.
Hello, ma'am. Thank you for that wonderful presentation. I was wondering whether there's an objective definition for frailty.
Yes, I'm sure there is. I can get that for you. I don't have that with my presentation. There are specific definitions for frailty, but frailty is mainly defined in terms of what it results in. So that is what leads to our definition of frailty. So I can send that across to you.
Thank you.
Madam, what she meant is that the bystander should be allowed to stay continuously in the recovery room.
Yes.
Not coming intermittently.
Correct.
One bystander should not change, but bystander should be allowed to stay in the recovery room.
So that is why it's very important that patients who really don't need recovery room care should be encouraged to be shifted out to their wards or post-operative private rooms as early as possible. So we should draw that line between making that very clear because we know that this is a risk. Post-operative care, again, ideal, that's the ideal world kind of scenario, but we have a way to go because we have our nurses who are trying to manage 16, 17 patients there, alarms going off, just like the ICU. So we have those same kind of issues. But that is why the emphasis on sending those patients, getting them to eat, drink, mobilize, and go to the ward, rather than keep them just for the sake of monitoring one or two things in the PACU.
Very good morning, one and all gathered here. Let me introduce myself. I'm very new to the BCMCH family. I've just joined yesterday as Professor and HOD of Emergency Medicine. But I'm an anesthesiologist with more than 3 decades of experience in the field. So it's a very a favorite topic of mine, and I want to congratulate Dr. Ashu for the fantastic presentation she has made. Perioperative medicine is a specialty that is coming up, especially after MD anesthesiology and critical care. Because anesthesiology has branched out to critical care, of course, emergency medicine, post-operative. It covers everything, as she has mentioned. So perioperative, the very fact that the preparation starts from the beginning, there are a lot of aspects to it, which she has covered in a very elaborate, maybe very concise, but it is the responsibility of the parent team or the specialist who is going to perform the surgery to make sure that the preparation starts before surgery. What I'm trying to say is she's covered a lot of things like nutrition, rehabilitation, psychological preparation. All this matters when it comes to the outcome. So prehabilitation is one, especially when it comes to orthopedic surgeries or wherever there is movement related, the muscle strength, the bone strength, everything is very, very important. So when you address all that, the recovery becomes faster. And temperature regulation, as we have mentioned, a very effective way is giving them warmed intravenous fluids, which most of the times, the availability of a fluid warmer may not be there. But this is an excellent way of maintaining normothermia in the patient, because that itself can lead to a lot of problems like postoperative cognitive dysfunction, acidosis, a lot of complications with hypothermia. And ERAS is another very important thing where, especially for major gastrointestinal surgeries, we have seen that the recovery is so good. And here also the nutrition matters a lot. The key, I think what she was trying to say is that rather than being reactive, we all get excited at what is happening during the intraoperative period. More than that, if it is a preventive or a preemptive, that is, you anticipate whatever complications that can happen and you try to prevent it, that really helps in going a long way in having a successful outcome for the patient. So taking all these factors, rehabilitation, nutritive assessment, psychological care or support, all this matters. And considering the age and frailty are not always equal. You'll find that a 90-year-old person might be healthier or much more robust than a 50-year-old person. So that is where the frailty, in common man's term. So we have certain definitions of frailty where age is definitely one factor, but there are other systemic involvement, or it could be cardiovascular, it could be physical, it could be bone strength. All these things matter a lot. So putting all these together, frailty also is graded as mild, moderate, and severe. So as the severity of frailty increases, definitely the postoperative complication also increases. So these are the few things which we need to keep in mind. And this is one of the reasons why perioperative medicine is coming up as maybe after you do your MD post-graduation in anesthesiology, we do have courses where the whole perioperative period is taken care of, which is very interesting. And the operating surgeons have to, there should be a very good communication between the anesthesiologist and the surgeon. And when it comes to emergency surgery, the treatment starts right from the emergency department. So that is where our role as anesthesiologists also matters within the emergency department. So it covers almost the entire spectrum. So this is what I would like to add on. Thank you.
Thank you, ma'am, and welcome to the hospital. Welcome to BCMCH.
Thank you, Dr. Ashu, for that wonderful presentation and the discussion. Now, it remains for me to welcome a few members of our staff who have joined yesterday on the birthday of Kerala. So we are actually very happy to welcome them. The first person has upstaged me. She has introduced herself more than I could do. And this is Professor Laila Matthews, who is joined as the HOD of our emergency medicine. And she introduced herself. She's an anesthesiologist mainly, but she has special interest in perioperative care, as she described. and also special interest in trauma care. And we hope we can enhance our postgraduate program in trauma and critical care. Thank you. With your welcome, madam. Thank you. Thank you. So you have seen her, so I'm not asking her to stand up again. Thank you. Second is Dr. Meha Mariam George, MD, dermatologist. Is she here? Dr. Meha, please come. Can you come here? This is Dr. Meha, MD, DVL in dermatology. She's joining as assistant professor in dermatology. She did her MBBS and MD in CMC Vellore, and her area of interest is medical dermatology. Welcome, Dr. Meha. I'm sure you will enrich our department. Thank you. Next is Dr. Ananta Krishna, MD General Medicine. Dr. Ananta Krishna, can you please come over? Dr. Ananta Krishna is MBBS from AIMS Bhopal and MD from Mysore Medical College. His areas of interest are rheumatology, hematology, and cardiology. That's good. So unfortunately, he has chosen hematology. I wish you had come to cardiology. So welcome. He has a number of publications. Case report on diphthetic polyneuropathy, case series on renal syndromes in snakebite, and he got a Best Poster Award in API conference in 2023. Congratulations and welcome, BCM. Dr. Suraj Sashidharan Nair, please come over, Dr. Suraj. Dr. Suraj is joining as a senior resident in rheumatology, and he's an MD from Amrita Institute of Medical Sciences, Kochi. His areas of interest are autoimmune diseases, so appropriately he's joining rheumatology, and I hope you will take up rheumatology as your career. And he has his research thesis was HbA1c in critically ill patient and prognosis, and he was a gold medalist in MD. Congratulations. Welcome to BCM. Thank you. Last but not the least, Dr. Sariya Sukumar. Please come over, Dr. Sariya. She is joining as senior resident in general surgery. She's MS General Surgery from BCMCH Pondicherry. And her special interests are breast diseases, hernia, research and publications, comparative study of skin staples and conventional sutures for abdominal skin wound closures. Which is better? Skin staples. Thank you. Thank you. So welcome, Dr. Sariya, to our general surgery department. I hope you will be able to contribute and learn from here. Welcome. I would like to welcome all of you to our institution and family of BCMCH. And whenever I'm chief of medical staff, and if you have anything to discuss, any problems to address, you're always welcome to come and see me. Thank you. Welcome.
Thank you all. With this, we close this session. Have a wonderful and blessed day. Thank you.